Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This is part 2 for invasive hemodynamic monitoring, and this is going to deal with arterial pressure. Now these Learn Shops are intended for all nurses and healthcare professionals, especially those who are going to be looking after patients with invasive arterial hemodynamic monitoring, and it really just reviews the fundamentals. And these fundamentals pertain to invasive hemodynamic monitoring, which can help you identify cardiovascular issues that place a patient at risk. So what are the learning objectives for this session? Well, we'll have a pre-knowledge review. We'll look at the indications for arterial pressure monitoring, certain components that are important, normal arterial pressure waveforms, and anomalous waveforms that you might encounter, and some of the nursing considerations when looking after a patient with arterial pressure monitoring. So let's look at the knowledge review. Complications of an arterial catheter may include which of the following: limb ischemia, decreased tissue perfusion, air embolism, or is it all of the above? The correct answer is D. All of the above. What about an Allen's test, which we reviewed previously in part 1? The Allen's test assesses which of the following arteries: the femoral artery, patency; popliteal artery, patency; ulnar artery, patency; or is it the radial artery, patency? The correct answer is it assesses the ulnar artery, patency. What are some of the signs of decreased tissue perfusion during the arterial line? And they could include which of these following: A, cold skin to the affected limb; B, pale skin in the cannulated limb; C, pain in the limb; or is it all of the above? The correct answer is it's all of the above. What about this one? The Dicrotic Notch on the systemic arterial waveform represents which of the following: that the pulmonic valve is opened, the pulmonic valve is closed, the aortic valve is opened, or has the aortic valve closed? Which of the following is correct? The correct answer is D. The aortic valve is closed. The components of an arterial flush system should include which of the following: a pressure bag, normal saline solution, a flush valve in the transducer, or is it all of the above? The correct answer is all of the above. Which of the following are true of transducers which are used in arterial pressure monitoring? They have to be aligned to the phlebostatic axis. They've got to be zeroed every day or as required. They've got to be primed to remove all the air. Or is it D? All of them are true. The correct answer is all the above are true. Okay, now let's review the basics. What is arterial pressure monitoring? Well, arterial pressure monitoring is monitoring the blood pressure using a cannula which is placed into an artery. So the actual pressure in the artery can be measured. And as a consequence of that, this provides a continuous measurement of the systolic blood pressure, the diastolic blood pressure, and the mean arterial blood pressure. What are the indications for arterial pressure monitoring? Because look, it's an invasive procedure, which is associated with any invasive procedure. It can cause complications. So the indications would include: you want to assess volume, you want to monitor fluid management, you want to see a response to medications. Could be vasopressors, could be beta blockers, could be any number of different vasoactive medications. You may want to assess ventricular function, left ventricular function in particular. You may want to assess the systemic blood pressure. So arterial pressure monitoring then is a form of invasive blood pressure monitoring, and it's done through the cannulation of a peripheral artery. And this form of monitoring is commonly utilised in the management of critically ill patients, or intraoperative or perioperative patients, or sometimes postoperative patients. What are some of the potential insertion sites? Well, remember, arterial lines can be placed in the radial, ulnar, brachial, axillary, posterior tibial, femoral and dorsalis pedis arteries. And in adults and children, the most common site for cannulation is typically the radial artery. So possible insertion sites then are the brachial artery, the radial artery more commonly, the femoral artery, and the dorsalis pedis artery. What are some of the required components that you would use when caring for someone or inserting an arterial line for hemodynamic monitoring? Well, you need a pressure bag, a flush system, the transducer manifold, an intra-arterial catheter, rigid, inflexible tubing, a hemodynamic monitor, and most important, competent nurses to look after it. So what's the pressure bag? Well, the pressure bag, this maintains a constant pressure of approximately 300 millimeters of mercury, and the rationale is to infuse normal saline at approximately 2 to 3 mils per hour. And by having a continuous flow of fluid, it prevents blood from clotting in the arterial catheter because of this slow, continuous infusion of fluid into the catheter, which I said approximately 3 mils per hour. If you have it pumped to 300 millimeters of mercury and you actually have fluid, normal saline, in the line. If the bag's empty, it's not going to work. The flush system. Well, what's the flush system? The flush system uses an indwelling arterial catheter for a continuous flush to keep the catheter conduit open, patent. Intermittent flushing is unacceptable because of the danger of dislodging small emboli into the artery, providing a threat of bacterial contamination, and possibly infusing an unwanted amount of fluid. The flush system for an arterial catheter. Then you've got the transducer. Well, what's a transducer? Well, a transducer essentially changes a physiological signal into a recognisable pressure waveform, which you've got to be able to recognise, which means you're competent. And therefore, it provides a continuous measurement of systolic blood pressure, diastolic blood pressure, and the mean arterial blood pressure. So essentially what the transducer does, without becoming too complex, is that converts a mechanical pressure inside the artery into a kinetic energy that can be translated by the monitor, the machine, into a recognisable pressure waveform for you to interpret. Then you've got the transducer manifold. Well, the transducer manifold basically holds the transducer. So the transducer is placed into the manifold, which is easily levelled by you to the phlebostatic axis. And the phlebostatic axis is essentially the fourth intercostal space along the mid-axillary line. And it's the phlebostatic axis that's relevant for supine patients and patients up to 45 degrees in the head up tilt position. Some of the academics say you can go to 60 degrees, but typically 45 degrees is the acceptable level. And this is where the transducer is levelled to the phlebostatic axis. What about the arterial catheter? Well, these days they come in kits. So an arterial catheter is basically a thin, hollow, polyurethane plastic tube that's placed into an artery. It provides a continuous measurement of the systolic blood pressure, the diastolic blood pressure and the mean arterial blood pressure, as I indicated previously, and it also allows for arterial blood sampling for blood samples that you may want, especially in arterial blood gas. And this is often called an arterial line in an intensive care unit. So you've got the catheters. Then you've got the transducer tubing. And the transducer tubing is approximately 48 inches in length. And it consists of non-compressible, rigid-walled, fluid-filled tubing, which prevents damping and inaccurate transmission of the mechanical or the physiological mechanical pressure to the monitor. And it's a rigid tubing, non-compliant, because you want the pressure from the artery to be transmitted directly to the monitor without any changes. If you include tubing that is now non-compressible or flexible or compliant or soft, this will result in an inaccurate pressure being recorded by your monitor. The monitor then, well, the monitor is for arterial pressure monitoring, and it's commonly utilised in the management of critically ill patients, as I said. And it's the monitor that displays the data which is required for competent nurses to identify normal and abnormal or anomalous waveforms. Competent nurses, hopefully proficient nurses, are what's required. When we look at transducer alignment, the transducers have to be in the right position, as I indicated previously with the manifold. So transducer alignment number 1 is the patient is in a supine position, or they can be at 45 degrees. But basically, the transducer level is with and at the phlebistatic axis. In the supine position, this is the fourth intercostal space in the right mid-axillary line. But it can be the left mid-axillary line as well. Essentially, you want to be close to the right atrium. Then you've got transducer alignment 2. This may be for patients now that have to remain in a lateral position. And this is the right lateral positioning, where the transducer level is with the phlebistatic axis, which is in the fourth intercostal space again, because that's the level of the right atrium. However, it's in the mid-sternal line. You may have a patient positioned in the left lateral position, which you still need to do a transducer alignment. Well, the transducer level is still with the phlebistatic axis, which is the fourth intercostal space. However, in the left lateral position, it's the left sternal border. But ideally, you would want the patient supine or in a position not more than 45 degrees, elevated head. Now let's look at the normal arterial pressure waveform. And we're not going to look at the figures, but you can look at the scales there anyway. I mean, typically here, a systolic blood pressure would be anywhere between 90 to 120 millimeters of mercury, unless you're hypertensive. So the arterial blood pressure waveform basically reflects systole, which is emptying of the heart or the heart's contraction, and diastole, which is filling of the heart or relaxation. When we look at the arterial blood pressure waveform, the first component that we're looking at is the anacrotic limb. This is the first part of the wave. And if you look at the diagram, you can see the anacrotic limb begins when the aortic valve opens. And it's the ascending limb of the arterial pressure waveform as the pressure increases after the aortic valve opens and it eventually becomes the peak systolic pressure. Now the anacrotic basically means it's the first part of the blood pressure waveform. And in the Greek or in the Latin, it basically means first or the upbeat. And during this phase, you get 75% of stroke volume being ejected from the heart into the systemic circulation. Then you've got the peak systolic pressure. Now the peak systolic pressure is the top of the waveform. And this is the highest arterial, really, aortic pressure in the system. And essentially it's the force that the heart has to exert on the walls of the aorta, arteries, each time it ejects blood from itself, the left ventricle. And this is the stroke volume. The stroke volume is the amount of blood that is being ejected with every heartbeat, every contraction. Then you've got the second part of the waveform, which is called the dicrotic. And this is the descending part of the limb in the arterial pressure waveform as the pressure falls to that of the end diastolic pressure. And end diastolic pressure is basically the lowest pressure in the arteries at the end of diastole. And dicrotic basically means twice beating. It's the second part. And it's during this phase that still, with runoff, flow, following the contraction of the heart, you get 25% of stroke volume being ejected. 75% anacrotic limb, 25% dicrotic limb. Then you've got the dicrotic notch. Notch is just Latin for cutting into. That's what it means. So the dicrotic cutting into, it's a notch or the cutting into the dicrotic limb. And the dicrotic notch is a feature of the pressure waveform in the aorta. And basically it defines the end of systole and the beginning of diastole. And it represents now closure of the aortic valve. At the beginning of the anacrotic limb, that was opening of the aortic valve. The dicrotic notch represents closure of the valve. So the dicrotic notch is where the aortic valve closes. Then we've got the end diastolic pressure. And this is the lowest pressure in the arteries, aorta. And this is the pressure when the arteries, or in the arteries, when the heart is resting after contraction, which is systole, which is emptying. And this occurs between beats. When we look at the mean arterial blood pressure, well, this is the average. This is the average arterial pressure in the aorta or the arterial circulation. And you've got to remember, there are lots of different blood pressures in the body. I mean, your cerebral circulation has got a different systemic blood pressure compared to your kidneys, compared to your skin, compared to your heart, your lungs, your liver, etc. So as a general rule, the mean arterial blood pressure is the average arterial or aortic pressure that occurs during one cardiac cycle. And it's considered a better indicator of perfusion to the vital organs than the systolic blood pressure. And how it's worked out is that the mean arterial blood pressure is essentially equal to the systolic blood pressure plus the diastolic pressure multiplied by 2 divided by 3, which gives you an average of all the different blood pressures in your body. And as I indicated, as far as the academics are concerned, or the physicians or the medical fraternity, that this is a better indicator as to perfusion for your vital organs than just the systolic blood pressure. When we look at abnormal arterial blood pressure waveforms, these are some examples and just a few. So you've got underdamping. And underdamping is when the waveform oscillations or the images are too big. They're too pronounced. They're too overdone. And this can lead to false high systolic blood pressures or false low diastolic blood pressures. And what are some of the causes? The causes could be catheter whip, which means the catheter is moving in the artery because of the flow. This can happen in hyperdynamic circulation such as anemia or sepsis. Or it could be related to inflexible tubing. You may have used the wrong tubing, or you may have put in a stopcock, or you may have put an extension set in, which again is not recommended. Or it could be the positioning of the catheter. The catheter could be against the wall of the artery and it's sort of being blocked to a certain extent. Or it could be the transducer. And so especially with transducers these days, they're disposable. And disposable isn't always the best. It may not work effectively because it wasn't made correctly or it wasn't made to last. Then you've got overdamping. And overdamping is when the waveform oscillations are sluggish. They're slow. They're smaller. And this can lead to a false low systolic or a false high diastolic pressure. And what are some of the causes? Loose connections. You've got the connections open to atmosphere. You've got air bubbles, which is now blocking. It's blocking now the transmission of the mechanical pressure to the kinetic energy, which is created by the monitor. Or you're using flexible plastic tubing, which you shouldn't be doing. You should be using non-compliant tubing. Or again, you've got disposable transducer issues, or if you've got hardcore transducers, well again, they may be old. Very, very, very old, and they may be ineffective. So when we come to troubleshooting pressure waveforms, there's a test called the square wave test. And the rationale for the square wave test is to test for arterial waveforms in arterial lines. And this test is designed to assist you as the clinical nurse or the physician or whoever the healthcare provider is who's utilising arterial lines to identify an arterial transducer that is over or under damped. It's not working properly. So how do we perform the square wave test? Well, this is when you pull the fast flush valve, the yellow indicator there that you can see, you pull it out. Some of them push a button. This one you have to pull out. It's a yellow flange. And basically when you pull it, you allow the pressure bag to deliver normal saline to the transducer at that pressure of 300 millimeters of mercury, which is very, 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 very fast. And this produces a square waveform on your monitor and your recording paper that rises very quickly, very steeply, then it plateaus, it reaches the maximum, and then it returns to the baseline sharply when the flush valve is released by you. So while you're pulling it, there's a flush out, then it reaches the top of its limit, plateaus, and continues until you stop pulling the fast flash valve, which is that yellow indicator. And then it returns sharply to the baseline. That's how you perform the square wave test. If you've got optimal damping, which means the best that you can possibly get, then after the fast flush, there should be only 2 oscillations when you release it. And the height of the positive oscillation should be 1/3 or less of the previous oscillations. So it indicates that your transducer is working correctly. And therefore it will provide you with correct data and readings for your arterial pressure waveform. However, if you have underdamping, then after the fast flush, there are too many oscillations. We said only 2. And in this situation, you've got 1, 2, 3, 4, 5. The cause is possibly you could have the incorrect tubing length. It's too long. You're using stopcocks, which again is providing access from the atmosphere. You may have a high systemic vascular resistance. They're hypertensive. And as a consequence of that, it provides wrong data and high readings. Then you've got overdamping. And overdamping basically means that you have one or no oscillations at all after you stop the fast flush. And this can be as a result of air bubbles in the tubing, a clot thrombus, kinking of the tube, incorrect tubing. You may stop tubing again. There could be stopcocks in the system, which again isn't recommended. And as a consequence of that, this will provide the wrong data and lower readings. If we look at some of the clinical abnormalities or anomalies that are associated with arterial pressure monitoring, these are just some of them. You can be hypotensive, or your patient can be hypotensive, and this can result in a small waveform, and you may have the Dicrotic Notch which is not visible. And this can also be seen, as we said earlier, in relation to over-damping. And this results in a waveform that is typically small, sluggish, and you may have a missing Dicrotic Notch. Then you've got hypertension, which could also be as a result of under-damping. You get a large waveform with double or triple notching, and as a consequence of that, you'll see a waveform that has got lots of notches in it. And this is because of under-damping. But it could be related to a clinical condition, which is hypertension, a high systemic vascular resistance, vasoconstriction of the artery. Then you've got cardiac arrhythmias or dysrhythmias. And this is where, have a look at the waveform, look at the ECG, where you've got the lines. And as a consequence of that, during the normal ECG beat, you've got a normal arterial blood pressure waveform. When the patient goes into ventricular tachycardia, those big complexes, if you don't know what ventricular tachycardia is, go and look at the Dr. Manny Learn shots to do with ECGs. Because these are common rhythms that occur in adults. So have a look with the VT in the after the first two normal beats here, look at the arterial pressure, almost gone. No cardiac output. That's why when you go into ventricular tachycardia, VT, ventricular fibrillation, there's no cardiac output, no arterial blood pressure waveform, and as a consequence of you need a code blue. So when you look at the waveform, there's just one PVC, the third beat, top, here, a premature ventricular complex, and as a consequence of that, look at the third arterial blood pressure waveform, almost nothing. So no waveform, severely reduced cardiac output. What are some of the nursing considerations that you should consider when looking after an arterial catheter? And these are just some of the complications. I haven't included all of them. One could be potential bleeding. It's in an artery. You could have potential hematoma. It'll bleed into the tissues. It's an artery. You could develop potential ischemia because of the compromised circulation. Remember, the radial artery is the one that's being cannulated, and it supplies the hand, and it's got a backup in the ulnar artery, which is why you do the Allen's test, to make sure that the ulnar artery is now patent before the radial artery is cannulated. If you're cannulating the brachial artery, there's no backup supply. If you now occlude the brachial artery, that's potentially a problem. If you occlude the femoral artery, that's potentially a problem. If you go to the dorsalis pedis, well, you've got the tibial, which can now provide backup. So potential ischemia is always something that you would observe for as a nursing consideration. Okay, another one is always potential infection. All invasive lines that breach the skin, there's the risk of infection. Okay, that concludes part 2, arterial line hemodynamic monitoring, this Learn shot. If you found this of any value, please recommend it to your colleagues, because this is about looking after hemodynamic monitoring lines such as arterial. If you're interested in following through, go to part 3 where we look at central venous catheters and CVP as hemodynamic monitoring. Thanks again. See you next time.